Okay, so the other thing I did also want to show you is in week 6 here. I'm going to share the screen. In week 6, a couple notes. You might not have noticed that if you scroll down a little bit, there is a lecture guide. There's a study guide / lecture guide. That's for what we're reviewing today. So you can, if you didn't notice it, and print it out, or you can pull it up right now if you have the fancy equipment, and you can just go through and kind of follow along with the lecture. You can do it later. When you like, if you need to rewatch it or you'd like to rewatch it, you can do it later. There's also a key, but I would anticipate I open it like later, because I don't want to just give you a key to write in answers you won't learn, but it's a way to check, to make sure you're on the right. And it's not graded. This is just for study. It's nothing you have to turn in. It's just an added study tool. So I wanted you to see that. And then I also wanted to talk briefly about the Dexter assignment that we're going to do next week. And I altered it a little bit. Last year, it was a full FMX. This year, I'm just doing a half of an FMX for the first one, which is kind of I don't know. I probably could have still done a full one, but I really wanted to basically give you some practice time. Some of you don't need the practice time as much. And so it may feel, but a lot of times when I have students who have never taken x-rays before, one of the things they feel like is they never have enough time with Dexter. The hour goes by so fast. There's a demo. The demo takes a half an hour. And it's like, you just want to sit there and take x-rays, because that's how you get better, right? And so that's why I made this first one a half of an FMX, because it will give you either, if you're slower, it'll give you more time to take it and critique it, or if you move faster, it'll give you time to practice. So either way, I thought, yeah, it's a good compromise. So you're going to take a half of an FMX. You can choose the right or the left. I don't have a preference, but 2 of the films have to be taken with a snap array, and you will take 2 vertical bite wings. You won't take 3 vertical bite wings. I know we talk about in general in patient care, you're likely going to take 3 vertical bite wings when you have a real human. But for this, you're just going to take 2. So take 2 vertical bite wings, use 2 films for the snap array, the rest with XCP. So it's kind of a mishmash, and then critique what you do. Only take those 9 films. Don't take any more than that and critique those. And then once I check you off or Teresa checks you off, take as many films as you want, fix the ones that you wish you'd done better, whatever you want to do. And so that's basically next week in the operatory. And then at the table, we're just going to do some exercises for shadow effects and analysis of errors. The analysis of errors that we're going to talk about today will feel very old school and outdated, and probably sort of irrelevant, because it deals a lot with traditional film. And the only reason this unit is still in here is because it can show up on the national board. And so we still talk about it, but every year people are always like, do we still have to talk about that? Because it will kind of feel a little bit irrelevant. So we'll see. One of these days, it'll probably not be there anymore. Okay, that's all I wanted to show you on Moodle. Any questions at all? I'm going to pull up the next PowerPoint, Diagnostic Quality. We're not doing panel. That's next week, right? I think it should be next week. Today's Diagnostic Quality. So we're talking contrast and density. Let me share this. Let me share. Okay. So these are the objectives for today. And so we want to review a few things. We want to review some basics here. So radiolucent, a structure being radiographed, it lacks density or a lot of density, and it permits the X-ray photons to pass through with little or no interaction. And an example of that would be airspace or periodontal ligaments or gingiva. And so what ends up happening to the radiograph? How does that appear on the radiograph? Dark. It appears dark. Radiopaque structures are dense and the X-ray photon is absorbed or it's sort of, they come up against resistance to pass through easily. So an example of that is enamel, dentin, amalgam, composite, bone, and how will that appear on the radiograph? Right, white shades of gray, white to shades of gray. But the more dense, the denser, the whiter it will show up. Okay, so ideal diagnostic quality is going to provide a very nice image with lots of shades of gray and a good density so that you have so that you can see a lot of information. So you want to have variation in your blacks and whites and shades of gray so that you can see all the different potential information that's there. Things that have to do with the bone, incipient decay, periapical lesions, you know, all sorts of things like that. So the main things that we think about in that envelope is density, contrast, same shape and size of the object being exposed. So we really are hoping that what comes out on our X-ray is a similar size to the real life size of the tooth. We're hoping for similar size and shape, and then a sharp outline. So we don't want a blurry outline. So those are like the four things that we're really trying to accomplish with a nice diagnostic image. So visual characteristics, first we'll talk about density. Density is just the overall blackness of a film. So if it's a very dark film, it's very dense. If it's a very kind of light film, then it doesn't have a lot of density. It's talking about its overall blackness of the film. And here's an example of one that's less dense and one that's more dense. Primary factors that influence film density is the MA. So milliamperage does affect density. The higher the MA, the darker it'll be. So the higher the MA, the higher the density. KVP, the higher the KVP, more powerful penetrating X-rays, the higher the density. And then exposure time. So a longer exposure time, you know how you change the little buttons all around the thing, that is changing exposure time. And the longer the exposure time, the darker the image. Somebody just took a film yesterday. They were in the right category. They were in the bite wing. They'd selected bite wing, but the film came out kind of light. And so their machine, we could actually turn up the exposure time. So we went from 0.16 to 0.2, and they took the film again, and it was a little darker. And that wasn't using the automatic tooth buttons. That was just manually turning up the exposure time a little bit. So if you're in patient care and you feel like your film is light, you can actually adjust that a little bit. Subject thickness. So that's going to be depending on the thickness of your patient's jaw and what have you, how big or small the individual is. And notice that it's opposite. So we're kind of talking about higher MA, higher KVP, higher exposure time, darker image. But if you have a bigger human, then their density will actually go down. You'll get the opposite because there's more material to get through. So everything else is talking sort of about power and length of exposure, but that's talking about the actual size of the person. So bigger isn't darker for when you're talking about human, but higher rates of exposure, higher is going to result in a darker image. So just notice that difference when we're talking about those four things. We also want to talk about the source film distance. So we're talking about source as in what's coming off of the tungsten target. That's our source. Inside the machine at the target, that's our source. And then we're talking about the film. So we actually want a larger, so source film distance is, So if you get that inverse square law where we get the divergence of the beam, right? So as that beam diverges and gets less photons per square inch, or however you want to measure it, it's actually going to become weaker, right? So you're going to get a lower density if that space is longer. So you have to think in the terms of flashlight. It's going to cover a bigger area, and each area that's covered gets a less intense part of the beam. So an example, doubling the distance gives a fourth the density. Halving the distance gives 4 times the density, so you get more of a dense image. Too much density means it's dark, it's going to conceal everything. Think everything in the shadows. Too much density is going to conceal everything, everything's in the shadows. Too little density, it looks foggy and washed out. You're going to destroy detail. You're going to lose detail. It's all white and washed out, and you're going to lose detail. Visual characteristics of density. So here's 2 more examples of a decent density and too much density. So secondary factors influencing density, developing conditions. This is with some traditional film. So underdeveloped films are going to be too light. Overdeveloped films are going to be too dark. And then film speed is going to. So this is not really going to affect us with the digital. So you could write on this slide traditional films only. But high-speed film with the same MA and same KVP will produce higher density than lower speed films, the same MA and same KVP. Film contrast, difference in density seen on a film. So now we're talking not about the overall blackness or the overall whiteness. We're talking about shades of gray. So variations in the detail, that's contrast. So when you think density, think overall darkness, overall lightness. When you think contrast, think the contrast between as it steps up from white to like a light gray to a darker gray to a darker gray, until you're to the black. So that's contrast. When we're talking about contrast, we're talking about 2 types of contrast. We're talking about short contrast and long contrast. And this concept confuses people. So I just say it over and over and over again and write it out a million different ways. But because we're going to juxtapose something that's going to feel like absolute opposites. So it's one of these things, it's one of these concepts that you just simply have to write it out, talk it out, and it'll come. You just have to think about it for a while. But so when we're talking about long and short contrast, think about short contrast as it's short, there's fewer options. Think about it in terms of options. You have black and you have white. It's short contrast. You can think of it in terms of something smaller, less options available to you. Long contrast has many shades of gray. So you're going to go from dark to medium grays to light. So short contrast, blacks and whites, long contrast, shades of gray. And they're on the scale. So that's the word I was missing here, but long scale, short scale. So it goes very quickly from dark to light. So you don't have a lot of detail here, but here gives you a lot more options for detail. So different densities, it'll show up in a different shade. Yes. Can you say it's on a scale? Like a color scale. Oh, so like a color scale, although no color, just black and white, but a scale of shades of gray. But yeah, you can think of it. I guess it's the absence of color, right? I guess blacks and whites and grays. Okay, so factors that influence contrast here. So example of loss of contrast caused by film fogging. So scatter, a lot of scatter can fog out your film and you'll lose contrast. Under or overdeveloped films will reduce contrast. But that again won't really pertain to digital, but again, if you have, say you picked the wrong exposure time, it might kind of wash it out and you're going to lose those shades of gray. MA specifically is not going to improve contrast. So when you think of contrast, we don't really think about MA giving us any benefit. I mean, it could be a little bit confusing because you might think, well, if it's washed out, we said MA is affected by density, and if it's washed out, I've lost my shades of gray. But we don't really think of MA as improving it. You can have an overall too light film or an overall too dark film, but all of those ranges will equally lighten and equally darken. You're not going to get a variation change by changing the MA. Does that make sense? So we say MA doesn't affect contrast. MA only affects density. Okay, so here's a visual. This thing, and I think there's a picture, I think there's another picture on another slide, but this is a metal, this thing with all the little steps, it gets thicker and thicker as it goes on. This is made out of metal. And what they do is they x-ray it. And this area down here, because the metal is thinner, the x-rays obviously go through it easier, right? Because there's less material. So it'll show up darker. And then as you get thicker and thicker and thicker, the x-ray photons will go through it less and less effectively until they don't really, you know, they've stopped at some point, right? So if you have KVP that is low, if you have, and what do we know about KVP and how it affects x-rays in general? What do we know about KVP? Powerful beam. We could think of it as like powerful x-ray photons. It's overall like quality, some quantity, but quality. So if our KVP is on the low side, if your KVP is low, what does this scale look like to you? If you were to guess and call this either long or short, what would you call this scale? Short. Exactly right, because you see you got all this black, a little bit of gray, and then it gets white. So if your KVP is low, you're going to have a short scale of contrast. 70 is right about where we live, but as you can see, when it goes up to 100, it actually gets even a little bit better, because look at how the shades of gray come in, the variation still improves, and we don't get to white until we're way up here at this thickness. So the rule is for KVP, a higher KVP will give you a long scale contrast. A low KVP will give you a short scale contrast. And then these images here just kind of show that in different ranges. You see the thickness and you see that X-ray photon coming through and like, you know, making it a certain distance and then being stopped because it's a low KVP, it's weak, it just can't get any farther, so it doesn't show up, so it's just white, you know, and this shows it in a different way too with the wavelengths. So that's what that slide is showing you about how it penetrates. Here's the same information, just in a different format. So we have low KVP, we have short scale, just black and white, very little shades of gray. We have a higher KVP and we have a long, oh, I didn't describe high contrast and low contrast. Where did I miss that? We're going to back up because I didn't, that's the part that's going to throw people. Where did I miss that? That's where, okay. So not only, so rewind, I'm going to go back for a second because this is a really important concept, which this is the part that I think throws people. So when you're talking about a short scale, that we know low KVP gives us a short scale. Here's the word that's gonna throw you. It's considered high contrast. And so why might it be considered high contrast? There's a higher contrast difference between black and white. Exactly. So we say it's a short scale. We achieved that with low KVP. And we call it a high contrast. So you see how there's a little flip-floppy with the words. It's like, wait, what? High, low, short, what? So it's low KVP, short scale, and high contrast. Because black and white, you can't get any more different than black and white. So it's like, so there's a very high contrast between the black and white on the X-ray. But on the opposite side, we have a long scale, so lots of shades of gray, lots of variation. We achieve that with high KVPs, and we call that low contrast, because between every one, it's just a little change. So it's low contrast between each shade variation. Maybe that's not as tricky as for some reason in years past, I'm like, but it seems simpler every time I explain it. So I don't know. If you want me to rephrase it, if anyone has questions, please don't hesitate to ask. So glad we backed up and did not skim over that. Lower the contrast. Yeah. Yep. Perfectly said. The higher the KVP, the lower the contrast. That's all. Once you have that concept, and then knowing that if one's called a long scale and one's called a short scale, but once you know that, the higher the KVP, the lower the contrast, then you've got it. You're golden. Okay. So yes. So that is putting all of that in one slide. We have high contrast, short scale, low KVP, low contrast, long scale, high KVP. So that is what is being said there. Okay, summary of visual characteristics. That's like the hardest part of this whole lecture. So do you guys feel good? It gets easier. I promise it gets easier. Because if that's the hardest part, you guys seem to be grasping that quite well. So density, so summary of visual characteristics. So with density, MA and KVP both can control density. We will see an effect if the MA is changed or the KVP is changed. If our exposure time is changed, you will see an overall lightening and darkening of the film. So that's density. Contrast, only KVP is the only thing that controls contrast. Take home point, star, star, star. That's what you need. That's what you need to remember that. Okay, so now some more characteristics of a good film. So sharpness. Sharpness is reproducing the distinct outline of an image. So where there's always going to be a blurry edge. There's just always going to be a blurry edge. But sometimes it's very faint and hard to see. And that's why we think, oh, it looks so sharp. It looks so clean. But there still is a little bit there, but we want to minimize that. And one thing we haven't really talked about, I know I've mentioned it to a few people in lab, but when you take a set of films, after you've taken your complete set, there's a little on the little toolbar up there that has all the different icons. There's one that says Edge Enhancer. And it's a drop down with numbers. And if you go to 7, and every time you go back into it, and you can't change it from 7 to 3 and back to 7. It is accumulative. So if you do 7 and then you do something else, it adds to it. So they're very picky about it, and that's why I haven't really brought it up. But when you're in patient care, after you take your patient's pictures, you can edge enhance to 7 and then you can save. But the doctors they were having a lot of issues with my packs, and the way contrast was being changed and brightness and everything, all these things were being changed, and edge enhancing was too much. It goes into a weird place where it's too much enhancement. So at first the doctors were like, just stop, just save them and we'll play with them. But now they're saying, okay, we can edge enhance to 7 and then save, like when Teresa or I come in and save your films. But you don't really have to worry about that too much right now, but we will, as the semester goes on, and especially when you finally take your FMX on your live patient, we'll make sure that we've done that. But anyway, so sharpness is reproducing the distinct outline. Magnification, you want equal enlargement of the radiographic image. So you don't want anything to be too large and blurry. Can you think of an area of the mouth where you will probably always get some kind of a distorted magnification? Likely, yes, you will always get some distortion on the canine shot. You guys are not wrong by thinking that, but I'm thinking specifically of the palatal root on the maxillary molars, because your palatal root, like your mesial and distal root, are always going to look pretty normal, but then you're going to notice like this bizarre elongated root that's usually almost always distorted because it's at a totally different angle than everything else. So you're always going to get this sort of extra magnification distortion of the palatal root in the maxilla. Image shape distortion, so variation in the true size and shape of the object being radiographed. So we're trying to, like I said, duplicate the real shape in the mouth and get that on the radiograph as close as we possibly can. So penumbra, this funny little word, penumbra, That is basically the edge of the film, the edge of the object, not the edge of the film, the edge of the object. And there's always going to be a little bit of like a fuzzy edge, but we want to minimize that penumbra as much as we possibly can. So penumbra, a fuzzy, unsharp margin surrounding the radiographic image, blur around the edges. It's always going to be there, but we want to minimize it. Okay, so these are some little concepts like that can be a little tricky. It helps. We go over some of this is kind of fun little playing around next week when we're in lab. I have flashlights and little plastic teeth and like shadow casting. Anybody who's a dental assistant, did you guys shadow cast in dental assisting school? Do you remember doing that at all? Yeah, like it's basically you're casting a shadow of a tooth, and then you move your light source farther, closer, different angles, and it changes your shadow, which kind of helps visualize what's happening. Nobody did that. Well, we're gonna do it. It'll be fun. It'll be fun. It's just playing. We'll play it and at table time. It's like I have preschool or something. But so I don't even know. I don't think I should be calling it table time because it sounds like preschool. Circle time. I'm like, table time. I don't know where they just come to me, and I don't think it sounds weird until I say it out loud. Yeah, it's a sensory table. That's what we're gonna have next. I know. You guys, I don't know how you put up with me. But okay, so geometric characteristics. So these, we're gonna play with these concepts a little bit more in lab, and it'll help kind of clear it up a little bit. But an image unsharpness can be minimized by keeping a film. So your sensor, we got our sensor as close as possible to the object that you're trying to x-ray. So just think, the closer I can get my film to the tooth, so that's the object we're trying to x-ray, the sharper the image will be. The more detail and the sharper the image will be, the closer those two things are. Now, what kinds of things could prevent that from happening? Tori, anatomy, like just anything, any shape of the shape of everything could affect that. But in general, because a lot of times when we're doing the paralleling technique, we can't get it as close as we want it because you need it parallel. And so what happens? You do what technique instead? Bisecting. So a lot of times we end up doing a bisecting technique to get it closer or to compensate for some kind of anatomy. But parallel is ideal, but that means you may sacrifice distance from the film to the object. So source film distance you want as long as possible, and then object film distance as short as possible. And those two things, and this gives you, this is a little bit like funky to look at for a second, but so here's our source, there's our target, and if it's farther away from the object, you're gonna, if you stay within this pink part, here's the image. So if it's farther away, you're going to actually get, it's still a little bit bigger. See how it's a little bit bigger? This is the real tooth, but see how it's a little bigger. But if you're closer, which is, then they moved the tooth. Okay, why am I having trouble understanding what I'm looking at? Okay, I had this all in my head before I came in. So this is going to be, I'm trying to figure out which one goes with which one. Because this is showing that they're the same. And then the farther away, you're getting bigger. But I thought they said that for it should be, okay, hold that thought. I'm going to think about it for a minute and then we'll come back to that. But but I know for sure for the actual distance, or maybe, oh, this, I'm getting them mixed up. This is the distance from the source and this is the closeness to the sensor. So this is the one that, okay, now I know. This is the one that is showing how if you keep the tooth closer to the film, this is the first thing that I said. If the tooth is closer to the film, you're going to get a more accurate image. And if it's farther away, you're going to get a more blown up image. And then this one is talking about the length of your BID or your PID, and how if it's a longer PID, so that means your target is going to be essentially farther away from the film, then you're going to get you're going to get a smaller, more realistic film than if you're using a short BID. See how much more divergence you get in the beam? That I was flip-flopping what I thought they were. I should label those better. But so this is a shorter BID here. You get more divergence in your beam, and you're going to get a more blown up tooth. So it's ideal to have a longer BID that's more distance from the target to from the source to the film, and then you're going to get a truer image. But it's better to be close for the object and the sensor to be close. So two different things, and these I need to label these better so I don't get so confused so quickly. So this one is showing the relationship between the tooth and the film. This is the tooth and the film. The closer they are, the more realistic your image is. This one is showing the distance between the target, like the length of your BID. So a longer BID is more desirable. It's going to give you a better representation of the real object, longer BID. Feel like that was a hack job. But just review that, and if you have questions, we can try and sort that out. Yes, longer BID gives you a clearer, more realistic image to the real object that you're trying to radiograph. And then the film and the tooth should be closer. So tooth, film closer, BID longer. Yeah. Why does the longer BID? It has to do, I think it has to do with the divergence of when you have a longer BID, it's funneling it longer. And so the divergence is going to be lower because you have this sort of like elongated tube that because as it just emits from the tube head, you just get this kind of spread. But if your BID is longer, you're just going to be funneling them shorter. And so when they come out, that's probably not a great explanation because you might say, well, isn't it the same if it's shorter? But it has to do with the spread. Okay. I don't know exactly a better explanation than that, but we could try and figure it out. Okay. So to summarize these points, the 5 rules that you want to go by to try and get the best image with the least amount of distortion would be your X-rays should originate from as small of a focal point. So you can star this one. This is going to feel like an obscure point, but it'll show up on an exam. So your focal point, which is your tungsten target, should be as small as possible. And don't ask me why a smaller one makes a better one than a bigger one, but it's just, that's the rule of the physics. So that's most of them are, it says between 1/2 and just over 1 millimeter. So, you guys have started using your probes. You haven't? Okay. You'll know millimeters very good, very shortly. You'll know the size of, so 1/2 millimeter to just over 1 millimeter is the size of the tungsten target, the little piece inside the tube head. So smaller the better. So you want a small focal point. The distance between the focal spot, which is your source, your tungsten target. We have multiple names for everything, it seems. And the object being examined should be as long as practical. So that's where your long BID or PID comes into play. The film should be as close as possible to the object being radiographed. So that's where you want to get your tooth and your film as close as possible. And then the long axis of the object should be as parallel. We know that from talking about the paralleling technique, as close as possible, as parallel as possible. And then the central ray should be as perpendicular. I kept trying to tease you guys and throw you off by always putting parallel, but your central beam should always come in perpendicular to either your bisector or your long axis of your tooth. So perpendicular, your beam should always come in perpendicular. So these 5 things are the 5 major things for what if all these things are put in place, then you'll have a good representation of the image on the film. It won't be too big and blurry or magnified. It'll be kind of a truer representation of the tooth without a lot of penumbra or blur. So that's the goal. Summary of diagnostic features viewed on a film. So an image should not be too light or too dark. That kind of makes sense. Where that's your overall density. You don't want it too light, too washed out, too dark. The 5 basic tissues should be seen. So this is where contrast comes into play. We want to see a distinct difference between the enamel, between that and the dentin, between that and the pulp. We want to see alveolar bone. We want to see the lamina dura, which is going to be like the outer part of the bone. We want to see the periodontal ligament space. We want to see soft tissue. Sometimes you can pick up some soft tissue. So all of these things, and then that folds into things like I said earlier, like incipient decay or just the start of some kind of periapical lesion or something like that. So contrast is going to give us our diagnostic information. And then periodontal space, lamina dura, and bone trabecula, that should all be seen, and that's going to get just sort of blurred out if the blurriness, or if the film's not sharp. All of that little detail is sort of just going to get blurred away, and it's just not going to stand out. The lamina dura is not going to stand out. Buccal and lingual cusp tips are supposed to be superimposed. Now, we've talked a lot about vertical angulation, and we know that 2 things can happen. If we have really obvious vertical angulation on a film, you'll get separation of the cusps. So the buccal and lingual cusps are going to be separated. But we also know that some people's teeth are just in their mouth in different ways. And so you may get some vertical angulation on one tooth, but none on the other. The cusps are perfectly superimposed on the first molar, and then they're separated on the second, just because their teeth are laid different in their arch. So it does come into play where the cusps ideally will be superimposed on each other, but expect some variation. Just because you see some separation, it's like, vertical angulation, that's it. And it can be. So it's a little bit of a tricky kind of part, and you just kind of get used to looking at a film and going, well, this just looks distorted. It just doesn't look like most films that I see, so that can be a little tricky area. All needed structures for an accurate diagnosis can be seen. So that's coverage. So that's placement. So like, have you gotten far enough down so you can see plenty of bone around the apices? Did you get far enough back so that you can see the 3rd molar space? Did you get far enough forward so that you can see the distal canine? All this, did you cover all your spaces adequately? So here's just an example. You can see, look at how the cusp separation is barely minimal here. I mean, there is the buccal cusp here is a little bit lower obviously than the lingual, but it's not too bad. Same here, there's a little bit of cusp separation, and then whoa, you get like this huge separation on the premolars. So it probably has, yes, there's likely a little bit of distortion here. There's likely some vertical angulation, and especially since we see such a variation between the palatal and the mesial and distal root, or distal, mesial and distal root. But so this is one of those ones where it's like, you could say, yeah, there's probably some vertical angulation, but this is also very likely because this premolar is probably set in their mouth different than the other teeth. So you're just getting more of a drastic. So I think it's probably both things are coming into play for the vertical angulation and then the tooth placement. I'm not entirely sure why this is here. This is obviously something that you can label all the different areas. It might be that this is probably what I meant for this to be, and I just forgot why I put it in here, but it just so that you could actually label all the things that you could see on a regular x-ray, like pick them out in an x-ray, and then you can see them in sort of a little drawing. So you could see there's little lines, so you could fill in these areas and kind of label them. But I didn't do that in the PowerPoint, so you may not. I don't know how far you guys have gotten in dental science, if you could actually do that yet or not. But did you have a question? Yeah. What do you mean Okay, so let's say this one here. So the bite wing is usually a really good example because it's hard to tell the difference between the buccal and lingual cusp on the bite wing. They're sort of just superimposed on each other. But then if you look at this PA, the buccal cusp is all, and we learned this when we talk about the buccal object rule, which actually Amy, the director, is going to guest lecture. She loves that. And so I said, come and do it. And she taught this class for 9 years. So that'll be fun for her too. So she's going to lecture on that. But when we talk about the buccal object rule is when we highlight this, but the buccal cusp is always the cusp closer to the edge of the film. It's just, it has to do with the beam coming in and hitting your buccal surface first. And so just the way the physics works and the way it ends up on the film, the buccal cusp is always lower, closer to the edge of the film. So this is your buccal cusp, this is your lingual cusp. This is the lingual cusp, this is the buccal cusp. So that's just, so you can see how here they're not superimposed. You can see a definite difference between the lingual and the buccal cusp. And then, but here it's not so obvious. So that's what it means by superimposed.
So the molar is superimposed because they are lingual.
They are far more superimposed than the premolars. Yeah. Yeah. You can see it even better though in the bite wing. You can see it, they're even more superimposed on each other. Like you're hard pressed to pick out the buccal and the lingual in the bite wing. So the image of the buccal cusp and the image of the lingual cusp are on top of each other. So you can't see the separation. But once you get a different angle, you start to see the two separate cusps. Was there a question?
So when you see the different cusps, that's a sign of the first one.
It is very oftentimes a sign. Sometimes it has to do with the placement of the tooth in the arch, but it can be a good clue. Besides the fact that if the root looks short or the root looks long, like does it look stretched out? Did you guys all see that Google Doc that I put together with several examples? Did anybody not see that there was a message? It's in the announcement in Moodle, and it's just a Google Doc where I threw lots of, because vertical angulation, I probably didn't spend as much time because it's tricky. Because some things, it's like, well, yeah, there's probably a little vertical angulation, but then some things are like, well, this is a lot of vertical angulation. So when you're in that little area, it can be hard to pick out and determine. But yeah, if you see quite a bit of separation between the buccal and the lingual cusp of a tooth, then you know you probably have some vertical angulation error happening. It doesn't mean that every time you see it, you're like, because it could just be the fact that the person's tooth is either in buccally verted or lingually verted, or that they were trying to take a paralleling technique and they didn't quite do it, but it's not quite a bisecting either. It's like they're somewhere in a weird zone. So they do have some distortion. So I guess that would fall under vertical angulation. Any questions there still? I know that's kind of a little bit of a weird concept. You guys are good there? You can always come and ask me too. We can talk about it after class too. Okay. That's it for that. That's all we have to talk about getting a good image. Is, you know, a lot of that stuff is done for you too. Like you know, you don't change the MA, you don't change the KVP, you do change the exposure time, and you do have a lot of effect of how you place the film in the mouth, but you only have so much control whether how close or far away to the tooth you are. But so there's very few things, but those few things can really affect the quality of the image.
Do you not have the foreshortening slides?
The foreshortening slides we talked about it was the week before you guys took the exam. So that's on week, is it week 3?
Two more slides.
I wonder, is that not, oh, you did? Okay, let me make sure that I have that I'm looking at the right one. Let me go into Moodle, hold on. Because this could be, I just updated it and saved it, and it should have saved in Moodle. But if you have a couple extra slides, then I may have to go and it might not have updated it. So can I just see those slides?
Yeah, it was just too cool.
Are they-
Not a big deal.
Oh, well, that's helpful though. So that shows actually a lot of what we were just talking about. Does anyone else have that pulled up with those two slides? It shows examples of vertical angulation. Does anybody else have that? So I'm not looking at it currently, but that's what it's showing and so notice how on a few of them, it's like you're looking almost at the occlusal surface. If you are looking at the occlusal surface, like feel like, even if it's just like tilted, like, so you're looking at like half of the, that is a definite, if you have that much occlusal surface in your image, you have there's vertical angulation error for sure. And you will likely have a fair amount of foreshortened roots because you've just like turned the tooth this way and you're looking at it more from almost like a top down sort of way. And so I think that's all those slides are. I'll go in and see. I don't know why they're not on this one that I pulled up, because they should have, but they weren't when I went through and updated, they weren't there. So I might have pulled up a different slide deck. So any questions on those at all? Yes. This one? Yeah. Yes. Yes. I know the mouse doesn't show up very good, but this lower cusp here, this whole thing all the way down to the edge of the film, this whole part, the lighter gray down to the edge of the film, that's your buccal cusp. And then this whiter cusp here, or here where you can see there's a little amalgam filling, but then this whiter part here, that's your lingual cusp. So this is a very definite separation of the buccal and lingual cusp. And then here, the molars, it's not as obvious. And it's not as obvious on molars. It's a little bit more obvious on premolars, but not so much on these maxillary ones. So that's showing the separation. And I wonder if let me just see something real quick. Okay, so this was just that vertical angulation document that I put together and sent it out in an announcement for you guys. So this shows a couple more examples, I think, here, if I scroll down. So you can see, like, these are pretty obvious, these roots just look squat, right? They just look shorter and more squat. Just like someone kind of went smush. And so that's just sort of what they look like. When you have some definite foreshortening, it can be confusing because people could have gone through ortho and their roots could have gotten smaller through an aggressive ortho. And so you might not have foreshortened, they just have short roots because of an ortho or just something, just the way that their teeth developed. So I feel like vertical angulation is one of those kind of difficult ones to pinpoint because there can be other variables that are at play. But here's another really good example of looking at very separated cusps. So you have a little bit fuzzier buccal cusps, and then you have a little bit sharper lingual cusps. These lingual cusps are closer to your film, so therefore they look sharper. Your buccal cusps are farther away from your film. And what do we say? We always want the tooth and the film as close as possible. So that's a perfect example. That's a really good visual that you can think of. That's why your lingual cusps show up sharper than your buccal cusps. But this is another really good, this is just a very good visual of the separation of the cusps. And then if we scroll down, this is, I mean, super duper foreshortened, a lot of separation. All of these are our lingual cusps, the whiter part, and then the lighter, fuzzier gray is the buccal cusps. And then this just kind of shows some examples of elongation. There's vertical angulation error in a bite wing, which you don't see too often. And then lots of elongation here, foreshortening here. It's kind of your side-by-side images so that you can compare. And that's it. So that was just some examples. So does that kind of give a good visual of the two cusps? Okay. Let me get rid of this one here. We'll go back to here.